And we are recording.
All right, this is Unit 5 of NPN 622, Spring Semester 2018, which seems incredible that it's 2018 at this point. So tonight's conversation is essentially to begin the groundwork and thinking processes around pain, chronic pain, and opiate use disorders because they are intermixed. And a lot of times what's going to happen is that you're going to say, well, I have never met anybody who's opiate dependent, or I've never met anybody who's got this stuff that you're talking about. But chances are, if you start asking people about their pain, that you'll find that there are more folks out there who have and live with chronic pain than you were ever imagining. Many people who've had chronic pain for years kind of stop talking about it to people because they know that many people really don't want to hear it. They do the best they can, but often won't mention the reason why they're in such a miserable mood is that they hurt all over and that they didn't sleep last night because of the pain. So this unit is to kind of sensitize you to the idea that chronic pain is different than acute pain. The treatment for chronic pain is going to be different, and we're not going into the treatment of chronic pain per se as much as understanding how the norepinephrine and serotonin pathways can be helpful in helping boost an individual's ability to uh, distract themselves from the nociceptive pain feelings so that they can go on and do their life episodes and events in their life without having been totally distracted by the fact that their brain is receiving signals that are not necessarily accurate or true. So if you would turn the next slide, Simone. To begin with, it's helpful to kind of understand what pain is. And pain, being an unpleasant sensory and emotional experience, is associated with actual and potential tissue damage, and is described in terms of such damage. And that's the International Association on the Study of Pain. And pain is affected, and this is a part that is helpful to keep in mind, that because not everyone's pain experience is the same, oftentimes a number of things will interfere or amplify how a person responds. Prior pain experiences will certainly affect that, how old they are, what their developmental levels are, because some individuals are capable of distracting themselves from the pain so it doesn't seem quite so intense. Their cognitive and communication skills will also affect their perceptions of pain, as well as how much fear and anxiety they're experiencing. So those are some factors that are going to affect pain that indirectly we're going to work on those particular factors. So next slide, please. So why are we studying pain and pain management in psych? We more than likely are never going to prescribe an opioid, but we're going to study this anyway. Why is that? Clicks, Simone? Pain is a symptom of many psychiatric disorders. Oftentimes with depression and anxiety, you'll find that people have somatic symptomology. They may have pains in their neck, back pains, shoulder pains, chest pain. They hurt everywhere. And this is part of the symptoms of that disorder as well as standing alone. So click again. And 1 in 5 adults worldwide suffer from acute or chronic pain. So undoubtedly, in the course of a day, if you're seeing adults, you may run across maybe out of 10 people, 2 of those folks are going to have chronic pain and may or may not tell you about it. Click again. So our job is to kind of detect, to quantify, and to treat pain, which has become a standard part of psychiatric evaluation. So while you may not be ordering an opioid or a non-sed to treat the pain, it is helpful to understand that it is there and to at least begin to address how this is interfering with the individual's life. Click again. So elimination of pain is considered part of the full symptom remission piece. Now, elimination is relative. Elimination, meaning pain is a level of 0, may or may not be realistic depending on the individual or the degree of damage and chronic pain that they're living with. So full remission of symptoms might be that they have elimination of pain as part of that process. So next slide, please. So where is all this directives coming from about looking at pain and pain levels? Well, back in the 90s, the Joint Commission, which at that point had a slightly different name, developed a pain standards which require screening of all patients for pain during their initial assessment, and if indicated, to do periodic reassessments. Now, JC, it used to be JACO, but now it's Joint Commission. They have been kind of on the hot seat for essentially being accused of having established this concept of pain as the fifth vital sign, which people are pointing to having triggered the opiate epidemic, which is not necessarily true. The pain as the fifth vital sign is something that was conceived of as a way of communicating this to providers, as a way of thinking about it, but Joint Commission did not have a platform in which they wanted people treated to 0 level of pain. So just for clarification's purposes. The Patient Protection and Affordable Care Act of 2010 identified pain as a public health problem. So those are a couple of different agencies and acts that looked at identifying and treating pain. Next slide, please. And so in this process, it's helpful to understand some of the physiological responses to pain. And we're just going to walk through this. In essence, do you need to have memorized this? No, it's helpful to understand that when people have pain, that it initiates a stress response, that it triggers hormonal and metabolic changes, which are mediated by the hypothalamic pituitary adrenal axis, your HPA axis. So when you're studying, it's kind of like, what do I really need to know about? Well, a lot of things use this hypothalamic pituitary adrenal axis as a major piece of understanding that particular illness or stress response. So understanding that better would be pretty helpful in understanding pain and chronic pain. So once that's triggered, it sets off the sympathetic nervous system, which stimulates the cardiovascular system and the respiratory system to increase O2 and organ perfusion. So because this is a fight or flight response at this point, it increases secretion of adrenal corticoid hormones, cortisol, catecholamines, glucagon, and growth hormone, and it inhibits insulin release, increases glycogenesis, and stimulates metabolism of proteins and fats. This increases plasma glucose, proteins, and free fatty acids. At the same time, the body is increasing aldosterone and valproisin, which is antidiuretic hormones, which essentially cause water retention in the kidneys to support cardiovascular homeostasis. So all of this is triggering off, which is, of course, beginning a process. Next slide, please. So when acute pain changes over to chronic pain, so acute pain triggers all these things and they're up and running. And this stress response has been going for a while. After a while, the body gets just tired of maintaining that degree of on. So acute pain serves a vital function. It is peripheral or originating outside the CNS, and the pain mechanism changes in chronic pain. It's either enhanced or perpetuates the original peripheral pain, or over time the pain changes from peripheral to central pain. So this is part of the understanding of the fact that acute pain and chronic pain are not necessarily the same. So next slide, please. Chronic pain hypothetically is caused by alteration of the pain processing within the central nervous system, and it's associated with many symptoms of depression and anxiety. So they're not really sure about this, and anything that's hypothetical alters with time and may change as more information comes down the pike. So hypothetically, chronic pain is a matter of information processing within the central nervous system that just basically kind of goes awry. Next slide, please. So some of the terms, and these are terms that you're going to want to know. Nociception, which is noxious stimuli, which produces activity in the sensory pathways, which conveys painful information. Aldania, which is pain caused by a stimulus which does not normally provoke pain. So this would be someone touches your arm and it feels very painful. Ouch, when somebody just touches you. And hyperalgesia is increased response to stimulus that is normally painful. So if, for example, somebody just hits you slightly, it is a stronger feeling because of the hypersensitivity that you have. So a little hit it feels like a big hit. So those are terms that are very helpful to know in this process. Next slide, please. Some of the main players in this process, I've got them named here just basically because it's helpful to consider that because of this, the spinal cord into the thalamus, that the spinal bulbar tracts go into the brainstem nuclei, and the somatosensory cortex, which is the region of the cerebral cortex, receives input from the cutaneous sensory nerves. So those are main players in the chronic pain and pain pathways. Next slide, please. And in the thalamus, which is one of the major players, you've got essentially each half the brain has a thalamus, and all sensory input except for olfaction is modulated in the thalamus. So if you consider that this is the big switching station, it just kind of helps with that process. And one type of nuclear group within is afferent impulses from the amygdala. And consider, what does the amygdala do? So this is where I say, okay guys, to your keyboards. Amygdala, what is its function? Okay.
Or just generally when you see amygdala, what kind of symptoms do you think of? What kind of disorders do you associate with the amygdala? Fear, okay. Fear and emotion. Exactly. Or smotion, which sounds better than emotion. I like that.
Okay. So if you couldn't get the amygdala, then you write that down in your notes for tonight. Double check, what does the amygdala do and why do I care? And it projects from the frontal cortex, which frontal cortex, very important for thinking processes, for executive function. And because this may mediate affective impulses or emotions, where else do you suppose this might end up? If it affects emotions, back into the limbic system. So next slide, please. So brainstem, all ascending and descending tracts between the cerebral cortex and the spinal cord pass through the brainstem, which translates to it's a big bundle, everything's got to go through there. Next, click again. So there's 10 of 12 cranial nerve nuclei originating from the brainstem. Click again. Which two cranial nerves do not originate in the brainstem? To the keyboard again. All right, Karen. Thank you very much. This is important in the sense is that when you're thinking about all of the pieces and how they fit together, 1 and 2 are much different than the other cranial nerves because they don't innervate anything outside of the brain. Next slide, please. So, other additional players that we have in this process are fibers, 2 types of afferent nociceptive fibers with voltage-gated sodium channels responsible for transmission of this noxious stimuli to the CNS include A delta, which responds to noxious chemical stimuli, and the C fibers, which respond only to noxious mechanical, heat, and chemical stimuli. So these fibers are targets in some of the medications that we're going to be looking at. So voltage-gated sodium channels. Next slide, please.
And y'all are probably all a lot smarter than me, but the way that I have to remember afferent and efferent is that afferent approaches the brain and efferent exits the brain, if that's helpful to anyone. Just going to share that.
Well, all the little tips that you can give is helpful because folks are studying and some of them don't have it all down yet. And I have to study this material every time. So it is not the simplest in the world, but it's helpful because as you're teaching your patients, it really is difficult to sell why you want somebody to take a medication if you can't explain how it's going to be helpful to them. So with the neurotransmitters that are part of this, we're looking at within the dorsal horn of the spinal cord. There's a dominant excitatory neurotransmitter, which you've met before. It's glutamate. This particular neurotransmitter is excitatory and a major player in this, as well as what other unit did we cover in which glutamate was a major player? It had to do with memory. Thank you very much. 2 points for you, madam. So glutamate mediates fast synaptic transportation. Calcium influx increases the sensitivity to glutamate and exacerbates the response to noxious stimuli, resulting in primary hyperalgesia. So the more glutamate's around, the more calcium influx floods into the area, the more sensitive the cells become, and so consequently this becomes kind of a circling process. Increases in glutamate increase the response to the noxious stimuli, resulting in a primary hyperalgesia, which is the hyperalgesia is a heightened response to a painful stimuli. So in the sense is that glutamate being excitatory neurotransmitter in this particular case adds to the damage. So next slide, please. So in response to this, the C fibers upregulate with calcium. C fibers, the upregulation of the calcium channels play a role in injury, evoking, and this is a repeat from before, the hyperalgesia and the allodynia. So next slide, please. The neurotransmitters involved in pain. Most of these you've seen before. Some of them you may never have seen before, but these are the neurotransmitters involved in pain. Inhibitory, serotonin, norepinephrine, the opioids, GABA, somatostatin, and the ghrelin. And excitatory, substance P, substance K, the glutamate, which we've talked about before, aspartate, the calcitonin gene-related peptide, cystokinin, and vasoactive intestinal peptide. So some of these we haven't talked about, we're not going to talk about because they may or may not be relative to psychiatric illness, but the glutamate is a player that's going to come back up and up again. So the more that you understand the relationship between the excitatory glutamate and the inhibitory serotonin, norepinephrine, the GABA, and the opioids, uh, the better that you can kind of think through how you can help a patient feel better. So next slide, please. So neurotransmitters are synthesized not only by the primary afferent, neurons, but also by neurons in the dorsal horn. So they're targets for known pain relievers. Opioids target this area as well as serotonin and norepinephrine. The SNRIs, alpha 2s, the delta ligands, which act on the voltage sensitive calcium channels. So if they can tone the calcium channels down, it tones down the glutamate. And the two medications which can do that is the gabapentin and the pregabalin, which is sold on the market as Lyrica. Next slide, please. So considering that there's this excessive and unnecessary ongoing nociceptive activity causing this neuropathic pain, by blocking the voltage sensitive calcium channels with these A2 delta ligands, which are the gabapentin and the pregabalin, it inhibits the release of various neurotransmitters. So in essence, it kind of dampens down this response. Next slide, please. So chronic pain, the effect of chronic pain is that it may cause atrophy in the dorsolateral prefrontal cortex. The belief behind that is that the area in the process of trying to manage the flooding of information that it keeps getting overstresses the area. And in essence, all of this is perceptual, what they believe that is going on. It's hypothetical and there's no way to particularly prove it, but this persistent perception of pain leads to overuse of these neurons and a cytotoxic cellular death in this brain region by the glutamate and a reduction in the corticothalamic brake in the nociceptive pathways. So it translates to once this stuff gets going, it causes exotoxic cellular death, which is what the glutamate triggers. And essentially, once it is moving, many times people continue to perceive pain while there is no longer anything causing the pain. So this is some of the underlying theory behind this. And this atrophy in the dorsolateral prefrontal cortex causes cognitive impairment in some folks in which they just can't concentrate and can't think. So while it seems like, well, it's because you hurt all the time that you just can't focus, but in fact, it may be that they're having brain changes related to the ongoing experience of having persistent perception of pain. So next slide, please. So part of this pain hypothesis, which the patient perceives pain when there's no obvious sign of peripheral trauma. And the descending inhibition cannot be acted on adequately to mask what they call as irrelevant nociceptive input. So under normal circumstances, you can distract yourself and not feel things that are happening or bothersome because you have the ability to kind of turn it down and turn it off. So for those folks who can't mask this irrelevant nociceptive input, by adding medications such as SNRI, an irrelevant nociceptive input is ignored and no longer perceived as painful. So that's kind of what they anticipate is happening when an individual has an SNRI. And the SNRI works much better than the plain SSRI. So this is kind of the medication that they found is most helpful because of essentially the balance between the serotonin and the norepinephrine. Plus, with some, there is an increase in dopaminergic effect in the prefrontal cortex, which improves the ability to think for some folks at some time. So benefit on multiple levels. So next slide, please. So the SNRIs, which are available, and some that are not available, is the duloxetine, which, depending upon how high of a dose that folks go, can start as low as 20 milligrams all the way up to 120 milligrams, either in a single dose or divided doses. This Savella is not approved in the United States, but has been on the market in Europe and other places for the treatment of fibromyalgia. Venlafaxine, which we know as Effexor, and desvenlafaxine, which is also effective, one time a day medication with less of the side effects that its parent drug had. And some TCAs also may have this same SNRI properties. Now, the A2 delta ligand, which we're talking about, the gabapentin and the Lyrica, or pregabalin, may help reduce anxiety as well as to improve the individual's sleep. So when you're looking at medications for individuals who have chronic pain, it is helpful to consider the total person about how much anxiety they're experiencing, because the more anxious they are, the more pain perceptions they're going to have. And improving sleep overall is going to improve their daily life. So we've kind of covered briefly the highlights of translation of acute pain into chronic pain. That these, Stahl devotes a whole chapter to it, and what I did was kind of synopsize what Stahl said. It is complex, but intriguing. And the intriguing part is the fact that your body is tricked into continuing to feel pain when no pain continues to exist. And that's essentially what happens with folks with chronic pain. And because the site in which this is occurring at is not necessarily the site that opiate receptors respond best to, is part of the reason why folks say opiates don't help chronic pain. They don't necessarily target the areas that need to be targeted. Opiates help some folks with chronic pain. And the tricky piece is, and as you are going through this unit, to look at individuals who have poorly managed pain look remarkably like individuals who are drug seeking, because they're not receiving a degree of pain relief from whatever it is that they're taking. So it's always difficult when you're working with folks with chronic pain and you're looking at opiates about whether or not this individual is actually becoming opiate addicted as opposed to dependent, because anytime anybody takes an opiate for longer than a 2-week period of time, they're going to be dependent on it, as one is dependent on a beta blocker for an extended period of time. You become physiologically dependent on it, but it's different than addicted, which includes continued use despite danger and cravings and withdrawal, et cetera, et cetera. Now, with dependence, you're going to have withdrawal. So withdrawal does not determine whether or not somebody's addicted to something. So next slide, please. What we're going to look at now is a real brief case study in which this particular person originally lived in New Orleans, but she was forced to leave during Katrina, which, if you have had any contact with folks who left New Orleans post-Katrina, that was an extremely stressful period of time. And just having had that experience might be a good reason to consider assessing further for PTSD symptomology if they were forced to leave during Katrina. So she'd been highly functional as a ward clerk at a local hospital, and she complains on presentation of poor sleep, fatigue, weakness, joint pain, poor concentration, and hopelessness. She has a poor appetite, but she's been gaining weight, and her BMI is greater than 40. She arrives in a wheelchair as she can't walk from the car to the office, so it's convenient for her to ride in a wheelchair. Her daughter is in the waiting room and brought her to the appointment. So in looking at this particular case, where would you begin in terms of helping to treat this person? What symptomology would you consider looking at first? So Sabrina would look at the depression and also the sleep. So generally it's helpful to look at low-hanging fruit. Um, there is no PHQ-9 on here to indicate the degree of depression that she's experiencing, but she's hopeless, she's not sleeping well, she's fatigued, she's wheelchair bound, and she's 55 years old, which she's still a young woman. And to be wheelchair bound after having a full life of being highly functional as a ward clerk is a great step back in her ability to function. So next slide, please. Uh, Back up one. There you go. So keeping the previous slide in mind, her current pain level is a 7/10, which is constant, and on some days it's a 10/10. I believe that this particular woman on several occasions also had scores of like a 15/10. And why can't she walk? She could walk, but because of the fact that her muscle strength and her overall muscle tone was so poor that it was taxing for her. So she had a wheelchair so that she didn't have to walk. So when you consider that a person who's capable of walking chooses not to walk because it is too stressful for them, that there are some issues that looking at getting this person as functional as possible need to happen, because at 55 to be in a wheelchair is a considerable degree of impairment. So she's got difficulties with her activities of daily living. She needs assistance to bathe, and she's currently living with her daughter because she's unable to live by herself. Her daughter does the cooking and the shopping, and she watches TV and cleans up some. So her role is very minimal and very dependent. The daughter reports she's up all night watching TV. So we have a report from the patient that she's not sleeping, but then she stays up all night watching television, which if you're living in a small house, having somebody up watching television all night is not necessarily going to help the other people who live there sleep either. So if we began by treating her depression, part of our activity levels might be what else? I think this is where we go to the next slide, Simone. So in a treatment plan, where would we begin? And it's been postulated that we would start with her depression. What would we look at for behavioral interventions? Would there be labs that you'd be looking at? What medications might you consider? And in terms of pain medication focus, what would you be looking at if you could, or we're going to regulate her pain medicine? What would you consider? So where would you start? And if you've got a microphone, please go ahead and use it. Okay, so you'd want to get TSH and A1C and general chemistry. Okay. So you'd essentially rule out the fact that she was less than functional because perhaps she had a thyroid abnormality or was in the process of developing diabetes with a um, BMI greater than 40. You'd be kind of concerned about that. Okay. If the lab's able to do that, cortisol levels. Anything else that you might want to consider? Okay. Um, Liver function tests. It's always helpful to know how their liver is doing, and particularly if anyone has had hepatitis, their functionality is generally not going to feel well, have low energy, may be contributory. So certainly a liver function test check. Um, FBG, I'm not sure what FBG stands for. Casey, could you use your microphone and explain FBG? Blood glucose. Fasting blood glucose. Okay. All right. Yeah, fasting blood glucose in an outpatient setting is always a little tricky. It requires the individual cooperate. Yes, you could consider that. I think in this particular case, an SNRI would be the major piece that we would be looking for. Sleep hygiene and teaching, and Cymbalta is definitely the beginning choice on this. Now, this particular woman was already taking, if I remember correctly, she was on Norco, so she was already being treated for her pain. But the issue is that even with taking medication 3 to 4 times a day, she was still having all of this pain and decreased ability to function. So you would choose an SNRI, something that you would be able to assess how her level of depression was. And as far as assessing for her depression, what kind of screening tool might you use? PHQ-9. Okay. Bex is pretty easy and quick to use. The main reason for using some kind of a screening tool is that for an individual such as this particular woman who was very somatic, that many times folks will come in and tell you about all the terrible things that were happening to them because they're somewhat socialized to tell their provider the terrible things that are happening. So a screening tool that the individual fills out themselves will take some of that element out of it. It'll also make it a wee bit easier for you to track changes, significant changes in mood, particularly looking for improvement with the medication. So a screening tool is very handy if you're not using one in the practice that you're in. Consider how you might incorporate it into your practice. I encourage you to consider that. And so we're looking at Cymbalta. We've got labs on this lady. What behavioral things would you want her to do? Now that we've got the lab set, we've got some medications already in the queue for her. What behavioral changes would you want her to try to make, or to essentially do some motivational interviewing with her to see what she was willing to do? No clue? With chronic pain, what are the major tenets of helping people to manage the pain is exercise. And the exercise is generally gentle, but with the focus on strength, increasing activity, that's true, with the concept that many times people with chronic pain have a tendency to do way more than they possibly can because they override their emergency system, and then they pay the consequence of the fact that they overdid it. So someone might get up in the morning and say, I'm going to get active today, and I'm going to walk a mile. Now, this particular woman, with her being wheelchair bound, say that she decided that she was going to get up and she was going to walk down to the corner and back. It would be a problem because the next day she's going to be hurting more because she's so out of shape. So beginning with stretching exercises, gentle tear yoga, increasing activities. Very good, Sabrina. This is kind of where you as a provider end up being a coach to talk with a person about how important it is that they look at what they can do to increase their own strength. The stronger that they are, the better the muscles can support their weight. And this particular woman with a BMI of over 40, her complaints are that her knees hurt, but she is putting an enormous amount of pressure on her knees because her weight has gotten so high. So part of this balance is going to be looking at reducing her overall weight so that she's not stressing the very joints that are painful to her. So this is a process of looking at a total person, and that the depression is one of the symptoms of where she's at in this helpless, hopeless state of living with her daughter and not having. Asking her about her diet would be helpful. Usually, a lot of times, what folks will say is that they don't really eat anything. Maybe you've heard other people say that as well, that I just kind of pick throughout the day. I don't have an appetite. But what they're picking on is always tricky. Oftentimes it's high calorie, high carbohydrate concentrated foods. So it's a total teaching process in terms of, if you're going to pick, what is it that you've got to pick at that might be healthier for you and less in salt and sugar loaded, particularly if they're pre-diabetic. People are more likely to hear you because they've got some interest in that. So asking about their diet, helping to encourage them to get up and to get moving. And then when they come back on the next visit, to ask them how they've done. And because this is a coaching process, to encourage and support whatever small changes that they have made. Because only focusing on their depression and only focusing on their pain is not necessarily attending to the fact that they may be making progress, whether they're aware of it or not. And to highlight the fact that last time you were here, your daughter wheeled you in a wheelchair, you were watching television all day and not sleeping during the night. And now what you're telling me is that you've been doing the dishes after meals. And so you notice what changes in her activities of daily living have occurred. So this process is a slow one, that folks who have chronic pain don't change overnight. That this is a over years period of time for some folks. And I mention that only in the sense is that the relationship that patients have with you is really important, because you have seen them when they come in and they're usually at their worst. And as you see them each time, to note and comment, particularly if you've got the PHQ-9 or Bex, to be able to say, well, last time you were here, you were a 20 on the PHQ-9, and today, even though you don't feel any better, your scores are lower. You got a 15, and so even though you don't feel it, something's changing. Please keep taking the medicine. So there are things that you can do when you're working with people to attend to the changes that are being made, because change is slow, and that this is a do a little, rest a little, do a little kind of a process, that most folks are unforgiving of themselves. And this process is also helping to teach people to appreciate their bodies for whatever they are, and to use them to help them meet their particular goals, whatever they are. How can you get there? Let's see if we can't get you stronger so you can do the things that you want to do. So we've kind of covered chronic pain, acute pain. We've looked a little bit at some of the things that set people up for opiate dependence, particularly if they get off on this track of, I have pain, give me pain medication to treat my pain. And as we move forward, we'll talk more about opioid dependence, the differences that may occur. Opioid dependence, as I said, is inevitable if you're taking opioids longer than a 2-week period of time. But because opioids themselves are not evil, what the issues are is that some folks abuse them, overuse them, and unfortunately, when people have been addicted to opioids, they stop them for a period of time, their set level of opioids that they were used to will lower. So if they've been in remission and clean and go back to using, that's the time when most folks end up overdosing. It's accidental, but because they're not anticipating their body's going to respond like they did. So I'm going to stop at this point. Are there any questions about this information? There's a great deal of information to read out there. It's really quite intense, and it is a helpful angle for you to understand about how you can help your patients. The more you understand, the better you can help them. So, questions at this point?
I was going to mention, a lot of y'all in Alabama may know this already, but there's new legislation. Let me not say legislation. Blue Cross has implemented a new policy. It'll start in April, that any opioid script for more than 7 days is going to require a PA from the prescriber for them to fill it. So that's new.
Yeah, it's new, but unfortunately, in these agencies adding additional issues to prescribing increases the complication to it. How are they fighting the opioid crisis? I think that that's kind of one of those finger in the dike things. At this point, the opioid crisis is not necessarily about prescription medication, but the opioid crisis is more about the fact that there's drugs flooding into this country through Mexico, from China, from South America, that have been synthetic and are considerably stronger than any of the prescription medications that are out there. For example, the fentanyl and the carfentanil. So the opioid crisis as it is has changed its face. Blue Cross, Blue Shield of Mississippi has implemented it as well. Yeah, I think that the issue is that when these companies make these changes, they add to the degree of difficulty for people to get the medications that they may need. Now, it's been recommended that prescriptions be written for a shorter period of time. It's been also recommended that you not write for opioids for things that could respond well to an NSAID, where previously dentists, when they wrote for when you had your wisdom teeth out, would you give you a 30-day supply of Percocet. So some of this is the prescribing patterns of providers, which once I'm going to write you this prescription so you don't come back and bother me again. But people store the stuff in their medicine cabinets and their teenage kids get into it. So how people get into opioids is variable once people got started on them, because opioids provide a number of things for people, one of which is it makes the pain go away. And pain being emotional as well as perceptual pain goes away with an opioid. And for folks who have not got an ability to tolerate stress, an opioid is a relief from the stress of life, which sounds kind of counter anything that you might be aware of, but for some folks who can't handle stress, that's their go-to. So part of this legislation is to, in essence, clamp down on what's available out there. But I'm afraid that sometimes all this legislation, regulations are enacted, but they generally are never removed. So the more spider webs that are out there, the more difficult it is to treat your patients and treat them as well as you possibly can. So that's kind of my 2 cents on that. It's a Band-Aid, in my opinion, but it's because it's complicated. They want to do something, and that's kind of what I take that to be. Other questions that people have? You're welcome, Karen. In the process, I think this coming up note that you have next is to look at individuals who either have an opiate use disorder or chronic pain, and beginning the question of asking people about their level of pain is always helpful to consider as you're moving forward, about assessing people for depression, also assess them for their level of pain. It's difficult to help people sleep at night if part of what's keeping them awake is the fact that they hurt. If you don't ask about the pain, you won't understand the full element of what is keeping them up. So, any other thoughts on this, Simone?
No, ma'am.
All right, well, what can we expect in the comprehensive final exam? Well, Michelle, you're kind of jumping the gun a little bit. It's a little bit of time between now and then. The comprehensive final exam, are you talking about the one that you take at the end of the summer semester? Okay. No, the comprehensive, the one that's called the comprehensive is taken at the end of 623.
I think, yeah, they're referring to the
final
comprehensive exam for 622, the one that they'll take on campus when they come.
Okay, see,
yes,
it's a final exam for this course. Better, thank you, Deborah. The final exam for this course is considered to be comprehensive, which means it covers everything that we covered in 622. In essence, I guess if you go and look to see what things were covered in those particular units, this one there is a very clear what do you need to know to study for this particular unit laid out for that one, for this unit, and it's already posted. So if you say, what do I need to study? It's there. But my recommendation is to kind of understand how these pieces work, so that when you're dealing with folks, you can kind of explain to them about why an opiate may not be the best choice for their chronic pain. So we got some people who wonder about this exam.
I think at this point it's scheduled to be about 60 questions, 60 to 65 questions, so a little longer than the previous 2 exams, and it will cover this new material, which is the chronic pain module, and then even proportions for the previous units that we've had. So very similar material. If if it was important enough to ask the last time, it should probably be important enough to bring it to ask it again. Let me see, what is this question? Information in the module has links. It's posted in the module. This, the PowerPoint that Dr. Fogger just went over is posted in, I think it's called Unit 5, Module 5, PowerPoints. And another one that's really important on stages of change, the Protraska and De Clemente model. But so yes, it'll be there for you in a printable version. Like this here. Just black and white.
Yeah, I had just updated this today because when I gave this presentation last year, I was not happy with the material as I presented it because I didn't think that I could figure out what I was talking about. But this time, if you consider the players, the fibers, and how they are affected, it works out a whole lot better. As I said, it kind of parallels what Stahl's got and synopsized what he said. Stahl says it better than anybody else, but at the same time, you can't necessarily spit out what Stahl says to a patient and anticipate that they're going to get it. This study guide too. Deborah, do you have a mic?
Yes.
I don't quite.
When you look at the email concerning this module, it did have a link in there that took you to a study guide. But for some reason, again, I did not see the study guide for this module. For some reason, I wasn't able to click on it in the module. So it was just kind of iffy how that's working. I just kind of typed it from my email, but I did not see it posted in the module.
I think it's got a separate drop-down box for what's in the study guide, doesn't it, Simone?
Yeah, we'll check it and we'll be sure it's available in enough time to study for the final for sure.
Okay, thank you.
Sure.
Any other thoughts before we close for the night? We wonder if chronic pain can be a major risk factor for dementia. Given the information in this chapter and the fact that chronic pain and stress causes an atrophy in the prefrontal cortex, I would imagine that the answer to that question is that it is a risk factor for it. And causes cellular death, yeah. So anytime that you've got that, it's definitely not something that you want to see happen. Glutamate is not necessarily a friend of the brain. And that would be kind of how I would consider that. But because our job is to kind of help people be as healthy as they can possibly be, to be coaches to them, to say, right now you're not happy with how things are, but to make the changes that are needed to be made requires that you work at this on a daily basis in little small pieces. So somebody's asking about somebody's dog. So at any rate, I think we're going to go ahead and close this for tonight. If there are no other thoughts or comments on this, people who have chronic pain are challenging, but I encourage you to consider the fact that they have been suffering and dealing with this for a long time. And somebody is asking, oh, how Coleman is. He's laying here at my feet. He's quiet at this point. He's partially deaf, so there's nobody around bothering him at this point. So, oh, he recognized I'm talking about him, so he picked his head up. But anyway, thank you, everybody. And I appreciate everybody being here tonight. And we'll see you in a couple of weeks. All right, Simone.
All right, everybody, have a good night. Email us with questions.